Good morning, everybody. So this is one of our first live Facebook feeds. We're going to try this out, see how it works. We are in Houston at the International Stroke Conference, and with me I have May Nour, who is the director of the stroke program at UCLA, and right behind us we have their new Gluck Stroke Rescue Unit. So we're excited, and we've got some questions. So these are some fun audience questions. We're going to see, we'll probably have folks walking in and out, and people can go in. Feel free to come on in the unit, and just don't worry that you're going to be on camera and live to like 26 people on Facebook right now, right? So welcome. First of all, just tell us a little bit about yourself and tell us about the program, how you decided, how y'all started it.
Absolutely, absolutely. So just a little about myself. I'm trained as a vascular and interventional neurologist, and as we know, stroke is a very devastating illness, so it's of utmost importance to treat the patients in a timely manner, and what better to treat them in a timely manner than go to them when they have the onset of symptoms. And we have the pioneer studies in Germany, which demonstrated that the mobile stroke units can actually get treatments to patients much faster than conventional ED care. So in the investigation now to look at the effect of giving clot-busting medications to patients in the field rather than waiting to receive the same medication when they arrive to the ER. And we feel that, and we hope that this will make a very big clinical significance in, number one, helping improve patient outcomes early, and number two, the other beautiful thing about this kind of mobile stroke unit, because we have the power of medical imaging and CT scan, is that we can have looking at the blood vessels of the brain, and in certain stroke subtypes where surgically removing some of the clot in the blood vessels is extremely important. It's very important to identify the patients who are appropriate and take them to a surgical endovascular center who can treat them.
Fantastic. So perfect, so wonderful. So we ask people to submit questions, and we have a few, and then if anybody else wants to ask, please feel free. So the first one says, what are the benefits in operating a unit of this size as opposed to a larger MSU? So, I mean, I guess depending upon where you are.
Yes. Absolutely. So it's very regional, right? So we are in the streets of LA, and going to a patient's home, I can't imagine taking the very large rig, which takes the full body tone, which can image kind of more of the chest and neck blood vessels. And so this unit provides us an excellent intermediate option, which is good size. People can move around in the unit, can treat the patient adequately, can triage as needed, but at the same time, it has kind of a small size, compact size, where we can actually arrive to the patient homes. The other really important things about these mobile CT units is that, contrary to belief, you may believe we pick up the patient and run and go, but actually for the CT scan to be performed, the unit has to actually be stationary. Not only stationary, but it has to be leveled. So we can't be on an incline, and we can't, this way, or this way, incline. So the unit has a way to adjust for that. To be able to level off. So we can perform the CT scan. So in theory, you arrive to the patient's home, you triage the patient, receive the CT scan, and if the patient is a good candidate for clot-busting medications, we start the therapy and then roll to the nearest hospital. Because the really time-limiting step is when you give the medication. Okay. So that's what we are trying to expedite.
Fantastic. Yeah, you have a lot of traffic out there in LA. Don't you win like top traffic jams each year? Okay, let's see here. So what were some of the deciding factors that led UCLA Health to adding a mobile stroke unit to their stroke program? So you already have an amazing stroke program. Why adding this on?
Again, we see this demonstration of the data from Germany, which shows that by using mobile stroke and by going to the patients, we can expedite the patient's care. The data we presented this morning, looking at analysis of the German study, it looks like there is a favorable trend towards clinical improvement in these patients, but what we're limited in is numbers. So as a group, national, international, and within the US, we have to collaborate together, pool our data, and show efficacy, clinical efficacy, because that's the important thing that's going to make this technology widespread, that's going to make the payers recognize this as a very important therapy for patients, and this way we can give patients in even underserved communities or underserved health communities the ability to have access to the fastest, high-level, speedy care, standard of care when they may otherwise not have.
Perfect. All right, let's see here. So this is an interesting question, particularly with the traffic and everything we said. Will you be using this near the hospital or farther out? So where are you planning on stationing this, or have you decided yet?
So that's a great question, and again, some of the preliminary data from Germany shows that about a 20-minute or 10-mile radius is the good number to aim for, because you don't want to delay the patient's care. So in our plan in LA, for example, with traffic, first our paramedic who's listening in on these radio signals will know kind of the time of day, where location is, whether or not we should dispatch to make it on time. But the plan is always, there is an EMS response unit that responds to the patient first. We go meet them there at the scene. If we make it there in a timely manner, we triage the patient and treat them appropriately. Otherwise, we don't delay care. The patient gets the regular standard care of going to the emergency department. So we guesstimate that about a 20-minute radius, and the answer to the question where this particular unit will be is that because, as Laura knows very well, the unit requires very specific power specifications, because the CT scanner has to be at a good adjusted temperature. You have to have a very secure place with the appropriate outlet and with room for the staff to be dispatched fast, just like a fire crew or paramedic crew would be dispatched. So for the current time, our first location will be UCLA Westwood proper, and the area we'll be serving is a 20-minute radius approximately from there.
And that's interesting because we know with some of the programs, one of the programs in Colorado, 1 week they're in one location of the city and another week they go somewhere else. So it'll be interesting as the program develops to see where it is that you want to be. And then of course, like the program up in New York, 20 minutes out could be 4 blocks.
That's
so.
Right. And just to add, ideally, you would want such technology in an area where there's the least access to stroke centers, because you want to facilitate in patients who really can't get there. And sometimes it's a matter of timing that the patient arrives to the hospital and they're outside of the IVTPA window. So can we save some of these patients by reaching them faster and being able to achieve a successful therapy?
Perfect. All right, let's see. So this is getting in your time machine and traveling to the next 10 years. Where do you envision mobile stroke treatment in the next 10 years?
I think that's an excellent question. Was addressed partially in the session this morning about mobile stroke. This is not limited to treating ischemic stroke. We are also able to diagnose hemorrhagic stroke by doing the CT scan, and we can start and initiate aggressive blood pressure therapies in the vehicle. This can also be the best venue to test out new novel therapeutic agents that are neuroprotective, because you get to the patient faster where you could never get to them before they arrive to the hospital. The other thing, from an interventional perspective, it would be very interesting to say, can we get the patient not only to bypass the ED, but also to bypass the ICU and go directly to the angio suite? So the thought of can we start in terms of groin sheath insertion, so the patient is actually very ready to go from CT scan, mobile stroke unit to the angio suite for thrombectomy.
And so one of these terms that we hear is time is brain. And so talk to us a little bit about how much time, if you're saving 15 minutes or 30 minutes, what does that mean to the patient? What does that mean for their recovery, their rehabilitation, and then maybe even the family that they're a part of?
So our genes, our lifetime experience, our exposure really trains our vascular patterns. And so some people have very good what we call vascular collaterals. So even if they have a vessel that's a large vessel that's occluded, it's just like you can't get to from A to B on the highway, you take side streets. Some people, their side streets, their what we call collaterals, are very well developed, and they can really sustain longer times of lack or low oxygenation to the brain. But others, once that vessel is occluded, time is ticking. And so I think people really deteriorate in a kind of a variable fashion, but the overall motto is time is brain. Brain injury is irreversible. Brain ischemia is irreversible if we don't act fast.
Well, so those were all the questions that we had here, and we have some folks out there. Does anybody have any questions that you would like to ask May? Oh, we have a question on our Facebook feed. Okay, so let me see. That's right. So thank you, someone out there in Facebook land watching. What is our question? You want me to read it?
What kind of staff would work on this rig? EMTs, medics, RNs, doctors?
Okay, great question. So it was asking about the kind of staff that's going to be in here. Are you going to have EMTs, paramedics, RNs, CT techs? How's that going to work?
Excellent question, and that is really a multidisciplinary team. And so the first person on the rig is a paramedic or EMT, and some programs have a combination, either one or the other or both. And another essential personnel is the critical care transport nurse, who will be physically administering the thrombolytic therapy and helping and giving some of the other medications. And a CT technician is very important, because you have to calibrate this machine and be able to operate it, be able to obtain the scan, and be able to transfer the scan in a very efficient manner to the person who's looking at it. And Dr. Jim Grata, who had the first mobile stroke unit in the United States at UT Houston, looked at the concordance in decision making by having either a vascular neurologist inside of the vehicle versus having that neurologist by telemedicine, and found a very good concordance. So initially, while they were having a physician ride along, you don't necessarily have to have that. We know that with telemedicine systems, especially the system we're going to be using called InTouch, it's very versatile, because this, if you want to zoom in on Scott, if you want to show them the telemedicine system here, so this piece of equipment, the telemedicine system, is now propped where the patient can be seen and can see the physician. However, that's very easily detachable. We take it in the field. We can go into the patient's home and see everything. Additionally, within our vehicle, we'll have an extra camera that has a zooming ability and really magnificent resolution. You can see up to the pupil size of the patient. So the physician will be able to assess the patient in a very clear manner. We'll be able to hear the clinical history. We'll be able to see the family members and collateral information. But also there's another neat gadget, which is a stethoscope, which has a USB connection, in which the physician can also hear the heartbeat of the patient and be able to see vitals and so forth. So everything now electronic, live, and easier.
That's amazing. Gone are the days where we took a Polaroid picture, had to put it in the mail and send it to someone. It's amazing what we can do with all of this technology. So do I have any other questions coming through? We have a question. Scott's doing the all-important money sign. How much is this thing, right? So I can answer that, and you can as well. But what we tell folks for the total capital outlay, meaning the Seratom, the ambulance, the telemedicine equipment, the point-of-care labs, everything, it's usually about $1 million. I mean, it can be a little above, a little below, but it's a sort of a nice round figure. And then, of course, there are operational costs that you'll have that are ongoing each year. And I don't know if that squares with what your experience has been.
Absolutely, I agree with Laura. So now, unfortunately, no way of direct reimbursement for activities that happen inside of the vehicle for most part. So what does it take for us to change things and make this technology very widely available? It's very expensive to start with. Most of the programs I've started in the US are philanthropically endorsed and backed by the institution. And so that's a really important donation that really is looking at this very nice pilot study and trying to validate the clinical efficacy of it. So we're in the clinical efficacy phase. Let's validate it together. Let's pull our data together. Let's show this makes a huge difference in patients' clinical lives. We will get reimbursement, and we will be able to break even and sustain this. So right now, what you can bill for is basically transport. But depending on where you live or what your arrangement is with your EMS provider, you may not even be billing for the transport. So in addition to that, you have to think of the cost of the IVTPA. That's $7,000 or $8,000 per patient. You have to think about the antihypertensive medications, the blood pressure lowering medications, the equipment, the personnel, the benefits, et cetera, et cetera. It really adds up. So we guesstimate with maybe a $2 $2 million or so startup. You can run the program for about 18 months before you have to have additional funding, or hopefully by then CMS criteria will change for funding because we can show that this is clinically efficacious and helps patients out. Then we can get reimbursement where after the philanthropic startup we can be self-sufficient. That's the goal. That's really the goal here.
Fantastic. And I know also on the billing question, depending upon what state you're in, there are different ways to license the ambulance and possibly the mobile clinic and potentially be able to bill for the IV TPA and for the scans. So I think we had an audience question. So the question is, and Dr. Nour was stating, here in Houston, the Houston Mobile Stroke Unit is a clinical study, and right now the Mobile Stroke Unit is on 1 week and then off 1 week and watching those patients in the off week and comparing. So are you intending to do it that way, or do you have a different setup?
So I think the most powerful way to analyze data or look at them are in a randomized fashion, in a blinded fashion, where we're able to assess really the efficacy of this type of therapy. So we will be joining Dr. Agrada's group, his grant called Best MSU, or it's a PCORI grant, multi-centered grant, and in that paradigm, they compare the treatment group inside of the mobile stroke unit and the treatment group who goes to the ED. So how do they do that? They do 1 week where the MSU runs, and they include those patients in the treatment groups and have all the appropriate follow-ups and so forth. And the other week, the critical care transport nurse, paramedic, or one member of their team are actually dispatched just the same as they would be dispatched for the mobile stroke call, except they don't go with the ambulance. They just arrive to the ED, examine the patients there, and they make a decision. Would they have picked up this patient on a normal on-week circumstance? If the answer is yes, they include that patient in the study, and those are the head-to-head comparisons. I think that's a very powerful way to do it. So we hope to join the study soon after we are live with our program.
Okay, great questions. Anyone else? Well, I mean, it's really exciting to see. I met the woman who cloned TPA yesterday, and seeing what a difference that makes. Also, the gentleman who developed the original CT scanner from Ceratom to make it so compact, and it's held up so well. So it's amazing to see where we've come over the last 20 years. So I think the next 10 years or even 5 years, we're going to see this technology move forward. Who knows what we're going to be using it for, but thank you so much, and congrats.
Thank you. I'll just add one thing. You guys have been absolutely wonderful in collaborating with us, because it's all about innovation, it's all about improving technology, and it's all about taking it to the next step. So we started with the first model that's kind of a retrofitted ambulance, but now we have incredible customization to allow us to have a refrigerator on the vehicle, for example, for medications that need special refrigeration, agents that reverse medications that thin the blood in patients who have hemorrhage. We're able to have this amazing technology, the telehealth technology, but also you have to customize it in the proper way. And you have to have a partnership with a great group of innovators, and we're very grateful and very proud to be in partnership with Frazer and InTouch. So thank you very much for your time.
All right. Well, thank you, everybody, and thank you, everyone in Facebook land. And we may try this again sometime. Thanks.